So now coming on from the complex cases, I would just go on for some basics of neuro imaging. So what are the common clinical conditions? I would be just dealing with how to read an MRI, how to read an CT, and how to identify whether it is a CT or MRI, and how to order and how to interpret. That's some basic things. So common clinical conditions when a patient comes to you with a vision loss, maybe bitemporal hemianopia, that may be the finding, or some junctional scotoma or some homonymous hemianopia, that means now the time for the neuroimaging. Anisocoria and ptosis. Then comes your proptosis. It can be because of the thyroid eye disease or any space occupying lesion that is involving the orbit or some metastasis, as the madam has shown in one cases of that your lateral rectus muscle. So here comes the role of the imaging, that too not only in the orbit, that too in the brain also. And diplopia or ophthalmoplegia, as Dr. Priya and madam has shown, supranuclear, internuclear ophthalmoplegia, some gaze palsy, definitely the neuroimaging is the choice. Then comes oscillopsia, the nystagmus as already has been shown, and importantly as an ophthalmologist, for you daily you are encountering the patients of papilledema. So now you have to think on whether it is a disc edema or papilledema. If it is a papilledema, so now you have to go for the imaging. And what imaging? I will just put one case and just show you. So the chronology, it will go like a little bit brush for the PGs and for the general ophthalmologists of the brain and the orbit anatomy, some basics of CT and MRI in relation to the orbit and brain, and interpreting the stain and how to start scans and how to and what to order, and little bit one or two common clinical condition and their imaging patterns. So this is the orbit, as you can see very well over here, the orientation of the orbit, the medial wall parallel, and these the lateral wall making an angle of 90 degree in the axial plane. And more importantly, you can see very well over here, this is the medial orbital wall. The optic nerve is it is at an angle of round about 20 to 23 degree with the medial orbital wall. It is very important to know this, because when you are ordering what to order, I will just show you in the next few slides. So this is an axial CT, as we come on to later on, and these are the certain paranasal sinuses which are around the orbit and which are very important for you to know to order the imaging. As you can see anteriorly, if I cut a section from here, you can see these are the three sinuses, the frontal, the ethmoid, and the maxillary sinus. Very well you can see in this coronal section. This is the maxillary, frontal, and the ethmoid sinus. And when you just cut a section from here posteriorly, so here is the sphenoid, you can see the sphenoid sinus. So now coming on to the skull base. What is the skull base? It is formed by, what is this? The sphenoid bone and the occipital bone. This is the clivus. So this is very important because it is also forming the roof of the orbit. Now lateral wall of the orbit, importantly it is formed by the wing of the sphenoid. Over here you can see, and it is very much in contiguity with the middle, that your cranial fossa over here, and here is the lying the temporal lobe. So this is again a important thing to know about. Then your optic canal, you can see very well over here, this is the optic canal from the one side, as over here this is the optic canal, this is the optic canal. So it is again contiguous with the middle cranial fossa and your anterior cranial fossa. So any lesion over here would be affecting the optic nerve, and you have to know whether to order an imaging or not, seeing the condition of the patient. And one more important thing, when you cut a section from here, so the muscle will be, this muscle would be okay exactly perpendicular, but the lateral rectus would be, if you cut from here, that means this is an coronal section. So there are what you call is quasi sagittal and quasi coronal, that I would just come later on. And canals and fissure, you know, this is the supraorbital fissure, again it is in contiguity with the middle cranial fossa, and this is your paracellar region. This is the sella and the paracellar region. You can see over here, this is the cella and the paracellar, the optic nerve are coming, this is the ICA, these are all that in the cavernous sinus lying, this is the cella and the paracellar region. So you have to order, while just encountering your third nerve, fourth nerve, or whatever diplopia, you have to order this cella, paracellar, coronal, axial 2 mm section with and without contrast, you have to order. So now this is the floor of the orbit. The only important thing is this is the infraorbital fissure lying over here. You can see seeing from above and from a sagittal section. So this is the infraorbital fissure connecting with the pterygopalatine fossa and the infratemporal and the temporal fossa. So this is again the maxillary sinus. You can see this is a quasi sagittal section. Now seeing upon these three films, now you have to think how to identify and how to read. So CT scan, I'm just going for the indication, then I would just come on how to read and how to identify. So CT scan, most versatile. Bony details, if you want to know the bony details, the calcification, some temporal or spatial resolution, then it is the imaging of the choice in a hurry, because the imaging time is very less. But the downside is 100 times more of the single X-ray, that the radiation you are exposing. So be careful in the pediatric patient. Nowadays there are machines which are producing less radiation for the pediatric also, the newer machines. But the other important thing is the beam hardening artifacts. What is that? When the patient is having any metallic implant or any metallic foreign body or dental implant, then what would be seen? These are the radiating. You can see over here spirally, or the radiating. These are the black and the white shadows. This is the whatever that foreign body is. So these are called the beam hardening artifacts. So now coming on to the MRI, it is a choice. Nowadays it is the only choice which you are having, apart from one or two indications for the CT scan and for the soft tissue, for the orbitocranial junction. Why? Orbitocranial junction is this, lot of bones are there, the sphenoid and the other bone. So if you want to know about the soft tissues, then you have to order the MRI. Imaging time is longer, definitely must screen for metallic foreign body. If there is patient comes to you that with a foreign body, and then there is an immediate history, then never go for a MRI if that is a metallic foreign body, because if it is in orbit it can dislodge, and if it is in brain, definitely it can do much more harm than your imaging, getting the imaging done. The cardiac pacemaker and that your the foreign body. In fact, now for the cardiac pacemaker also, because nowadays the 3 Tesla MRI are in more vogue, but still with 1.5 Tesla and with little more less ferromagnetic radiation, you can in fact nowadays with the softwares you can just do the MRI in the patient with the pacemaker also. So now as in for the orbit, as MRI for the preferential choice, all these are the indication. I'm not going to just go again for that. And for the CT, again the orbital trauma, foreign body calcification, osseous. And one more thing, when you want to know the bony destruction, is the bony destruction, how you would come to know, because the MRI would not show the bone. So whenever there is a tumor in the brain and you want to know whether the thinning of the bone is there, then you have to order the CT scan. Again, for this your brain imaging, when you are seeing a patient of only ophthalmic, that your ocular concern, and you want to order imaging, these are the indications you have to think in your mind: the demyelination, tuberculosis, TBM, NCC, neurocysticercosis, anemic core, you must be knowing about in the COVID era, and cranial nerve lesions. Then the detection of foreign wood body, your wood foreign body, because the that would be missed on your CT scan also. And pathology near, as I showed you, and this is how to that you know about any head injury, you go for that CT scan, and all other I have already illustrated. Now this is the gantry of the CT scan. Little bit about how you must have heard of about 64 slice, 128 slice. What is that? 64, 128. This is the gantry. These are the detectors. This is the patient lying over here. So these are the detectors. This is the patient lying on a couch, and these are the detectors. Earlier they were single. Your radiation was given, and the time taken for the CT scan, I'm talking about in 90s, early 90s or late 90s, and single detectors was there, so lot of radiation was the patient has to be exposed. But nowadays these are the detectors, number of detectors, 64, 124, 128, either they are lined, they are stacked in rows. So according to the number of detectors, and then maybe 64 or 128, or these 64 or 128 might also be having sub detectors within them. So these are the number of detectors. So according to them, this is 64 or 128 slice. And now what is doing, in spite of instead of giving these single radiation, spiral radiations are now given, so that not on a single 1 millimeter of the tissue is left for the radiation that is being exposed, and you can get every detail of the area what you have exposed. So CT versus MRI. Now how to know? The bone is bright in CT scan, you can see over here, and the bone is hyper dark in the MRI. You can see over here, this is the bone, this black. And no, you know what is this? This white is the bone marrow in the bone in MRI. So bone is black on MRI, but the marrow is little bit white. And what is this whiteness is? This whiteness is the scalp, that is the tissue, soft tissue. This is bright. So interpreting the scan. Now the patient detail, it would be there, all the annotation they would be showing the patient details. And now this right side, lower side, Again, there are annotations. These would be showing what this MRI is, whether it is a T1, T2, fat set, everything would be written over here. So how would you come to know with the, this is the right and left, this is right, 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 because without these annotations you won't be able to know whether this is right or left. Many times the experienced radiologist can get confused, definitely. So the right, left, and this is an MR venogram. You can see this is left written, and one more thing, whether you are seeing it from anteriorly, this venogram, or from posteriorly, it is also written over here. This is the P, that means you are seeing it from posteriorly. So these are the image plane. I am not going into detail. These are the axial, these are the coronal, I have already shown you, these are the sagittal. Now one more thing about the bone window, window. This is the soft tissue. You can see this is density, isodense, and this is the bone. So this is the bone, bright, and furthermore bright, and you are just attenuating the soft tissue, then you call it as bone window on the right side. So intravenous contrast, why to give, which one to give, or this all dependent upon the radiologist, but you should know as an ophthalmologist when you are ordering, because they serve to improve the sensitivity and the specificity of the diagnostic images by the altering the intrinsic properties of the tissue. What we are just using is the intrinsic property of the tissue in the CT scan, and that too in the MRI. So these contrast, they are just absorbing into those tissues, and they are emitting the radiation or whatever they are doing. Now you are just making the sensitivity and the specificity is more. Better delineates the structure due to differential contrast uptake, because the lesions, that they can be inflammatory, there can be tumor. So difference in their uptake definitely leads to the diagnosis. And in cases of trauma fractures, I don't think that you have to write the with MRI with and without contrast, only with MRI or with CT scan plain. Now contrast, iodinated. Nowadays iodinated are used because why iodinated? Because iodine is the substance which is more hyperdense on the imaging, and nowadays we are using non-ionic and isoosmolar, so there is minimal reaction and metabolic alterations. And in gadolinium, what CT scan we are using iodinated, and in MR we are using gadolinium. This is water soluble, paramagnetic, ionic, and non-ionic. So the only concern is nephrogenic systemic fibrosis. That is the reason always when you are sending the patient for MRI with contrast, always just get your creatinine or KFT done. So now contrast and non-contrast, how would you know? This is, can you see over here, this is written, sorry, over here, yeah. So this is homogeneous. It can be homogeneous because of the aneurysm or varices. It can be heterogeneous because of the tumor, hemangioma, rhabdomyosarcoma, and inflammatory. So in those cases, it can be heterogeneous. So what I was showing you, this is the image 9 and this is the image 6. 6 plus C. If you are not able to whether this is contrast or not contrast, see the annotation, plus C would be written. One more thing I am just giving you, this is your basilar artery. So contrast would be filled in the vessels. So this is the basilar artery in front of your midbrain. So this is what is your contrast. The vessel is seen. So contrast again, very well you can see this is the contrast taken up by the glioma, and this is again you can see the brightness. These are the brightness, these are the brightness, these are the uptake by vessels. One more thing over here you can see plus C. This is what I just wanted to show. This is plus C. So these are basic sequences: T1 T2 weighted, T2 fat sat, and T1 fat sat. That means the fat is saturated and post contrast. Thin section I'm not going into detail now. These compare this. This is as you know, white is fluid. White fluid is what? White is what? Fluid is white on T2. But this is T1, this is what? Black. Fluid is black. But now one more thing. This is your gray matter. This is white on T1. So apart from seeing the vitreous and the CSF, you can also see this is the gray matter. Outer is white matter. Outer is the gray matter, inner is the white matter, and it is hyper intense. Now again you can compare T2 and T1 images. I'm going into this one, T2 and T1 now. This is white, this is black. And the muscles, as you can see, they can be iso or hyper intense or intermediate intense. Fluid is bright. Signal void. What is signal void? Signal void is where there is no signal. When there is an air or when the vessels are there. So the blood would be high flowing. So it would not take any that your radiation, or it would not emit anything. So the flow void, they are called flow void. So fat sat, this is sagittal. Now one more thing, you can see these two images. Again T2, and this is also T2, but what is happening? The fat is bright, but over here this brightness has gone, so this is fat set. So T2 fat set. To better delineate the lesion, T1 fat set and T2 fat set. So you have to in orbit, you have to suppress the fat. You can see very well over here, this is again, and this is now. The fat is saturated. The extraocular muscles, now they are becoming more prominent. Now this area, this retro-orbital area or the ocular area, you can see this is the orbital area, the fat is not saturated. Here the fat is saturated, so very well the extraocular muscles are delineated. Other sequences are, you can see this is a flare sequence, fluid attenuation, inversion recovery. You can see this is the T2, this is again T2, but the fluid is attenuated. This is white, this is black. Why it is done? To know the demyelination in and around the ventricle. So flare mostly are done in demyelinating cases when you are encountering optic nerve or you are just suspecting multiple sclerosis. This is one maximum intensity projection. One sequence madam has shown a third nerve. Nerves are very difficult to visualize. So what? These are certain sequences. One BFEE, CRIS, and this is maximum intensity projection. You can see the fourth nerve and over here the sixth nerve. This is ascending on the clivus, which I told you, the base of the skull, ascending on the clivus. So cavernous hemangioma, one is dynamic MRI. You can see very well over here the filling of the the contrast. So definitely you can see on the console dynamic MRI, and you can just later on put this on the films also. So this last case and last slide, my just another sequence what you have to know about is intense headache, 28-year female, restriction, diplopia, decreased vision, left eye. So seizure episode की history नहीं थी, no any other neurological deficit. The only positive one that she was an obese female with a history of recent weight gain. Vision was 624 in the left eye. There was a grade 1 RAPD, bilateral disc edema. I will show you that means not disc edema, it was papilledema and generalized constriction of field. This is the restriction of the movement. This is the papilledema, as you can see, bilateral, and this is the restriction of the field. Now the imaging of choice. What would you order? This is not plain MRI. MRI either with contrast, with MRV with contrast. Why? You can see very well over here. This is MRV, which I showed you. We are seeing it from posteriorly, and this is the superior sagittal sinus. The pictorial representation is over here. This is the transverse sinus. This is the transverse sinus, and this is the junction of the sigmoid and the transverse sinus. So over here you can see this is stenosed. So MRV with contrast in any case, a female middle-aged coming to you with papilledema, so definitely you order MRV with contrast importantly. So patient was investigated for coagulopathy and anticardiolipin syndrome was there. So MRV I have already shown you. This is the optic nerve glioma. Optic nerve glioma on the MR you can see very well over here. This is your optic nerve. This is your optic nerve. This is again, which sequence is this? This is fat sat T2 sequence, coronal fat sat T2 sequence. So fat over here, fat is not saturated, and now again you can see post contrast. This is taking up the contrast. So optic nerve sheath meningioma, I think the time is gone because the other speaker have to just commence. So now I'm just leaving all this, and take home message is ophthalmology should be aware of specific clinical indication of CT MRI in neuro-ophthalmology and be prepared to recognize the distinctive radiological signs for each clinical entity. And one more thing, now the resident would not just keep the film away, they would just look upon that report. Please just pick the film, try to identify each and everything. Thank you.